Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Hello, and welcome to the Mad in America podcast. My name is Julia Lejeune. I'm a doctoral student in clinical psychology at the University of Illinois at Chicago and a science news writer at Mad in America. This week, we will hear from Dr. Morgan Shields. Dr. Shields completed her Ph.D. in social policy at Brandeis University and is currently an assistant professor at the Brown School of Social Work at Washington University in St. Louis, where she also directs her own research group. Dr. Shields is one of the few health policy researchers who focuses on quality of care within inpatient psychiatry. She has published over 25 peer-reviewed articles in outlets such as Health Affairs, Psychiatric Services, and the JAMA Network. She has also completed several policy reports for entities such as the U.S. Health and Human Services Office, and has served as a legal expert in cases related to psychiatric patient discrimination. Dr. Shields' research exposes the ways in which current healthcare settings are influenced by power imbalances, profit structures, and organizational priorities that fundamentally misalign with the human needs of individual patients. Her research has affected change at the state and federal levels, prompting internal investigations and structural reforms within agencies such as the Veterans Health Administration and the Massachusetts Department of Mental Health. Today on the podcast, we'll be discussing Dr. Shields' current work, which aims to identify strategies for implementing patient-centered and equitable treatment within existing mental health care structures, and in doing so, reimagines inpatient psychiatry. Dr. Shields, thank you so much for being here and taking the time out. I'm honored to have the opportunity to speak with you. And really, just to get started, I know that you're one of the few health policy researchers out there who's chosen to dedicate your career to studying inpatient psychiatry, to understanding quality of care in that setting. And I'm curious to hear a bit more about your journey to get there, your background, kind of what has gotten you into this work, what's kept you committed to it.
Yes. So that's the question that everyone likes to ask me. And they've been asking me this question for a decade. And it's interesting because I think I get asked this question more than other health services and policy researchers. So if I were to study primary care, for example, I just don't think there would be as much curiosity or fascination as to why I'm so interested in primary care. What's the story, right? But for me, there is this curiosity, and it's actually been something I've struggled with. How much do I share? How much do I leave to a person's imagination? And even if I don't share anything, people have imaginations, and it's really caused me actually a lot of distress throughout my training. And now I'm at a point where I have a faculty position, and I was very open about my who I am in my job applications, which was very risky, and it worked out wonderfully. I mean, it just was so great. So now I kind of feel very empowered and free to be a bit more relaxed about explaining why I truly am interested in what I research. So I've always been interested in mental health care and inpatient psychiatric care for multiple reasons. So I grew up with a father who was diagnosed with bipolar disorder, and he really did struggle. So he was homeless for most of my childhood. And we would see him, and he would sometimes be sleeping at different people's homes or on couches or in his car. We had a close relationship with him. He was in our lives. And the hospital was always this place that my mom would fixate on when my father would be experiencing, a manic episode or psychosis. She would say, if we could just get him to the hospital, and she would dream up strategies of trying to trick him or get him into the hospital, because if he could just get into the hospital, he could sleep. Maybe he could get better, but at least he'd be safe in the meantime, and there'd be some reprieve. So I grew up thinking the hospital is this place of safety. It's where someone could get treatment. And the fact that my father did not go to the hospital voluntarily was his fault. And so I was very frustrated with him. He was the cause of why his life was stressful and why my life was stressful. I have other family members too who have what you might consider to be serious mental illness, bipolar, schizophrenia, and have been hospitalized over a dozen times. But then I had my own experience, and my first experience in a psych facility when I was 16. And that, without sharing too many details or anything too heavy, the sequence of events was there was a huge traumatic event that happened in my life. My mother's boyfriend took me someplace and raped me. It was a big deal. And then the police were involved and it was very stressful. And so shortly after that, I just couldn't cope with the stress. So I was hospitalized. And while there, the frontline staff, who were comprised of mostly men, made fun of my breasts being too small. No, and I had just been raped. I went through strip searches, and there was a 9-year-old boy who was crying because he missed his mom and he wanted to go home. And this guy who had just come out of the military, and he was the primary bully of everyone. Frontline staff said, "You need to just man up and stop crying. If you would just behave yourself, you would not be hospitalized." And so I got upset and told the staff, "Stop yelling at this boy." So then I got restrained. And as punishment, it was scary. It was a lot of strong men holding me against a wall and then sedated. And then as punishment, they took away my clothes and I had to sit in the hallway in a gown and write an apology letter. So that was my first experience in a psych facility myself. And it was extremely humiliating, dehumanizing, and was the opposite of what I thought was going to happen. I really thought that this was going to be a place where people would be nice to me and they would realize that I was suffering and they would give me treatment. And I was very excited about getting some treatment and some positive attention, but it didn't happen. I had another experience when I was 20. And at that time, I was taking classes at a community college in Florida, and my father was in a manic episode himself. And I was also working, and there was a lot of stress. So I was put on an ADHD medication, Vyvanse, and I went manic. And I have, certain, whatever it might be, in my family, people go manic. So I'm sensitive to stimulants and stuff that I consume. And that was a horrible experience, the mania itself, and I voluntarily went to the hospital so that I could sleep. And I was restrained immediately for asking a question in front of my mom. And I thought they were trying to kill me at the time. And when they injected me with the chemical restraint, I asked them, "What did you give me?" And they didn't answer me. And I thought for sure it was lethal injection. And so I thought I was dying when I was going to sleep. And it was a near-death experience for me. And then anyways, there were a couple of hospitalizations with that. And it was extremely traumatizing, abusive. And I was not a great student. But what ended up happening is I moved to Ohio and went to Kent State University. And just sort of by luck and the kindness of an instructor, I was invited to work in a psych lab. And I fell in love with the research process. And I learned in interacting with the world that I could not talk about my experiences, because if I did, people would no longer think that I'm smart and capable. They would discount me, and I was afraid that they would send me back to a psych hospital just by uttering it. And then I kind of started talking about it with my colleagues, grad students, and they seemed to not be aware of these realities in the hospital. You really have to experience it in your own flesh and blood to really appreciate what it feels like to be so dehumanized. And because now I'm a researcher, I went to the literature and I saw that there was almost nothing in the United States being done on this. And I had all kinds of questions like, why did I go to this place that seemed to be for people that no one cared about? And why was everyone there not white, basically? I was the only white person. Like clearly there was clustering of certain patients in facilities that were worse than others. But why was that? So I became very jazzed about this, very passionate, upset, and straight from undergrad went into a public health master's program at Harvard and went in with a proposal to interview patients and frontline staff to really understand what's their experience like, what's happening, how does it vary, how common was my experience? I didn't know. And from there, I've been very hyper-focused, got a Ph.D. in social policy, continued researching this, did a postdoc in implementation science and academic community partnerships at Penn, and now I'm faculty at WashU Brown School. And it's social work, public health, and social policy. And I think it's a really good spot for me because I think that I very much align with the social work values. And I'm very optimistic about where I'm at currently. And throughout this process, I just get more and more energized because I get burnt out and then energized because I realize that there isn't really much going on. And when I speak with patients and I hear their stories, it just really ignites me. It upsets me. And so it's not so much my own experiences that fuel me anymore, really. It's folks that I speak with and that I interview in my research and the stories that I hear. And also my knowledge of like how messed up our accountability and data infrastructures are. So the more I learn, the more outraged I get, pretty much.
Thank you so much, Dr. Shields, for just sharing and your willingness to kind of be candid and open about what you've been through and what drives you. And I can say too, it resonates, and I appreciate you speaking to that experience of, being silenced in the process of, or feeling like you can't share this truth of who you are. Why is it too that there's this curiosity, right? That people want to know why you're doing this, what's your stake in this, but also such a lack of any available information on, what's really going on within these systems, except beyond, personal lived testimony, investigative journalism that's revealed these dehumanizing practices that are really widespread. What do you see as sort of these like structures that are justifying that lack of data or the exclusion of that data?
Right. Yeah. Excellent question. And there's a lot going on. First of all, it's my opinion, and it's also, this opinion's informed by my experience kind of trying to do this work and speaking with stakeholders and policymakers and payers. And researchers. So this is a population, and it's weird to talk about the population as a population when I identify as being part of the population in my family, right? It is a population in general that people are afraid of. They have discomfort towards mental illness in general. I hate to use the word stigma, but it really is an othering of people who experience psychological distress or find themselves inside of psych facilities. So much so that people don't even understand who is being hospitalized in psych facilities. And I myself get frustrated when I hear researchers who have certain questions having to do with quote unquote serious mental illness, and they conflate inpatient psych patients with people with quote unquote serious mental illness. And I say to them, what exactly do you mean by this term serious mental illness? And why do you think these are one and the same? This is a catchment tank for all kinds of stuff. It's basically the system in our society not knowing what else to do with someone. I mean, it's a lot going on, but I've spoken with people who have been hospitalized because they're trying to get away from an abusive spouse, people who've consumed substances and had a psychotic experience as a result of substance use, ending up in these facilities. It's just a variety of issues. But I think that fundamentally it's an othering of this population, a discomfort. And because of that, people are kind of afraid to touch it, like researchers, but also feel like they're not qualified to touch it. Like it's this special population. And like I know so many of my colleagues do research on so many aspects of the healthcare system that they have no lived experience with, like nursing homes, and they feel totally qualified to do it and to ask all these questions. But when it comes to inpatient psych, they'll say, oh, well, that's not my expertise. Really? But you could ask the same questions you're asking when it comes to nursing homes. And why do you think you're an expert on nursing homes? You have never been in a nursing home. So I think that the root cause is the othering of the population. And this might be provocative, and I'd love to hear folks' thoughts on this who might be listening to this. The only reason that the system is going to care about psychiatric patients or accountability of psych facilities and improving our data infrastructure at the end of the day is if they're faced with pressure. The system's not just going to change just because it's altruistic or, everyone thinks it's the right thing to do. It takes resources for one. It takes effort and there's inertia, and providers don't want to be held accountable in general, like not just for psych facilities. So it takes political will and it takes pressure. Now, I believe that the advocacy coalitions and organizations that otherwise would be putting pressure on this issue don't want to touch it because people have said this to me, directors of advocacy organizations, that they no longer invest in conditions improvement because they're very much, rightfully so, focused on keeping people in the community. And there's this tension or this perceived tension that if we advocate for improving psych facilities, then we're essentially advocating for more resources towards the psych facilities when actually we should be putting those resources towards the community and alternatives to hospitalization, right? And that's this tension. And there isn't necessarily like a clean fix to this, but the reality is that there is a vacuum of pressure. And I think that contributes. That's what, it's a population that is othered. It's easy to dismiss. And so without some sort of explicit organized pressure, nothing is going to change.
Sounds like both people are avoiding going there. And also there's people, some of that work's great of reimagining alternatives, but then that leaves like in the lurch of what's the black box of what's really happening.
Yes. Oh, and can I just add with this black box, I'm happy you said that term, black box. There are multiple stakeholders that are invested in keeping it a black box. So it's not just provider organizations, it's policymakers, regulators. And I'm not going to disclose what state this was, but I'm using this as an example. So for example, there's a state I'm aware of that they had these psych facilities and they happened to all be for-profits. They were conducting fraud, right? They had unlicensed, unsupervised staff. Patients were dying in their care. Patients were being put on 12 plus medications. Totally hard to fathom how that's appropriate for very healthy young people who then died from over-medication, etc. Multiple violations. But the states, and this was leaked in a newspaper, was the regulators were afraid to take away their license. They were not following the rules to maintain their license. So therefore they should have, in theory, lost their license. That's the consequence. And if that's not the consequence, then it's fake, right? There's no point in having rules. And if facilities know that, then why should they invest in adhering to those rules? So they were afraid to take the license away because they needed the beds. And they were afraid politically of having too much ED boarding. And the hospital systems don't want ED boarding. And they are pretty powerful lobbyists. And you want to keep people happy. And you don't want there to be a news article about ED boarding of psych patients. So, but again, it just kind of exemplifies that they are responsive to pressures. It's just, how do you make them be responsive to patient-centered pressures? Because they don't want the journalism coverage of the ED boarding, but they also did not like the journalism coverage of patients dying. So I think eventually a psych facility or two ended up closing eventually, but it took a lot of spotlighting.
Well, one question I have is, what would that pressure look like? What do you imagine those pressures being at what points in the system? And then also kind of who is currently benefiting from the structure as it stands?
First of all, I do want to say up front, something I really struggle with my research, and my research is going to evolve with time, is that currently the questions I've been asking are very much rooted in the existing status quo and structures. So how can we make reforms? It's very reform-based. It's not radical. And I struggle with that because some of the fundamental issues I see with psychiatric care in general are deeply structural within the mental health care system, but also outside of it. I think that the medical model, unfortunately, is might be inappropriately used for a mental health, but that we have invested a lot of energy and resources, and there are powerful entities that really benefit from us anchoring mental health treatment within the medical model. And all of our structures are surrounded by the medical model, insurance coverage, literally everything. And so I'm not sure who, aside from, yes, there are some profiteering organizations out there that are financially benefiting from psychiatric treatment, and that's an issue, and they have been increasing. But I also think that the issues we see are kind of a derivative consequence of our dependence on the medical model, and I don't necessarily think that any one psychiatrist or necessarily an association of psychiatrists like that some patients get hurt in psych facilities, right? I don't necessarily think that they appreciate that, but I think that there is, in my opinion, a knee-jerk defensiveness to any sort of critique, and I think that comes from, as a collective organization that has their own interests in mind, a fear of losing their footing, their authority. And I think that is exacerbated by the realities that within medicine, psychiatry is seen as it's a stigmatized profession, and their legitimacy is questioned even within medicine, right? And so they kind of have an insecurity there. So then when they're faced with any sort of critique, they can't see how they are very powerful, because maybe they don't feel powerful within their own home of medicine. That's just my own psychoanalysis of it. But I think that their defense of their profession and their footing and their stake really gets in the way of progress, and is kind of what is sustaining our status quo and preventing us from doing anything truly radical and truly alternative to our current models of quote unquote treatment. And, so I have found psychiatrists, I work with some psychiatrists who are amazing, but I have found collectively that they are the most offensive. And they tend to not be the ones working on the front line of psych facilities. And it tends to be nurses and social workers. And I find nurses and social workers to be way more sympathetic and understanding and actually have aligned interests, because actually what makes these environments better for them is better for patients. Yeah, so I guess this is to say, who do I think is benefiting? I think that there are some professional societies that benefit from this power struggle, right? Fundamentally, whether or not that means they benefit from people being hurt in psych facilities, I don't think they do, but that's kind of an end result. And then, yes, there are other profiteering companies that also subsequently benefit from psychiatry maintaining power in the mental health space. And then I think there are other stakeholders that benefit from not having to be bothered with the really, really hard, heavy work of reimagining true transformation. I think it's really hard. And that's for anything, not just mental health, any sort of huge change, like policing, for example. So, and what change is needed? Well, I think I kind of alluded to this. I'm optimistic, but I'm also pragmatic. I think the root issues here are power imbalance. And so for me, any sort of intervention that I try to dream up, I try to anchor it towards how is it addressing power imbalance between patients and the other actors. And so one tool that I have been really anchored around has been the measurement, reporting, and incentivizing of patient experience. Very incremental. I don't even know if that's going to end up being a good intervention, but it seems like a good first step since all of the rest of healthcare is doing that. So why aren't we doing that for psychiatric patients? It definitely smells like discrimination to me, that we're not systematically measuring patient experience at the national level and incentivizing performance on those measures. So, but the reality is that those measures can be gamed, that patients might be afraid to report how they truly feel, that, when you get into the weeds of it, you can really rip it apart. And that's just one. But anything that truly puts more power into the hands of patients, either at the individual level or as collectively as an advocacy coalition, I think is the way to go. That's how our imagination should be anchored around, that is addressing the power imbalance, in my opinion. And I support testing out alternatives. And I would love to research that in the future iterations of my work for sure, alternative crisis response. But I am also worried about how it is going to be co-opted and how it's this tension between accountability and true patient-centeredness. It's tough because you need there to be accountability, but it ends up turning everything into a formula and everything becomes standardized and credentialed and measured against the medical model at the end of the day, which isn't what we want. And then it kind of repeats itself. So I support understanding what alternatives are best and for whom, but I'm cautious about its implementation in our existing structures.
Yeah, I'm curious. You mentioned patient-centered outcomes. I know a lot of your work has been focused on that, especially more recently. I'm curious, given this messiness that you're laying out of how complicated it is to fit into these systems or make change within these systems, and I know patient-centered outcomes is also a term that's used in other medical spaces. For inpatient psych, how do you define that? What do you see as when working towards that? What does that look like?
For me, it really is, I'm just focused mostly on what I think is the first step, which is patient experience measurement. And you can think of patient experience as an outcome, but it's really like a process. You can categorize it as an outcome, but it's really the patient is evaluating the process of care. And the reason why I view that as a first order priority is because we don't want care to cause harm. And we want patients to be treated with respect. And that is important. When it comes to other outcomes, like the classic outcomes that are currently being measured are readmission and follow-up. Did you have contact with a healthcare provider within 7 or 30 days of discharge? Were you readmitted? Those are not patient-centered outcomes necessarily. Those are very much payer-centered outcomes. We measure those because they're easy to measure, because you can look at readmission and you can look at utilization of outpatient providers in claims data. And it's something. Feasible measures end up being readmission and follow-up. But those are so crude, and they're not necessarily the outcomes that are most important to patients, right? The problem with them also is that, and there's truth here, is when you speak with healthcare providers, the hospitals, they don't like those measures for any specialty, but mental health in particular, they'll say their arguments, which, and there's truth to this, is how can we be responsible for their follow-up or their readmission? We're just a stopgate. They come here you don't pay us enough to actually provide them any treatment. This is their argument. They're only here for a few days. We can't possibly give them any sort of like treatment. We're just trying to stabilize them. There's all these other social issues that they're dealing with, the patient. So we discharge them. We can't control outpatient capacity. We can't control housing. And it's not fair that you're making us responsible for that. And that's this tension. And I would say, instead of measuring those utilization outcomes, we could just ask patients directly. If we were to measure their experience, we could have some questions that just ask, did you feel that your care benefited you? Did you, whatever? And that would be an intermediary outcome that we can assign responsibility to the hospital, but doesn't creep too much into, the realm of community care and like all of the other factors that influence those outcomes that are outside the control of the hospital. Because there's political tensions and trying to implement this type of measurement. So that my first step is patient experience measurement. And then just, you ask the patient, how did this impact your trust, your willingness to engage in care? What was the impact on you? But you're not necessarily looking at the more like distal social outcomes. So fine, if the hospital wants to game those measures, maybe one way they could try is actually to perform on them, which is to be nice to the patients. Or, I'm speaking very simply, but it really orients. It's like the payers are saying we actually do care about what the patients think. So you can't just discount them. And I do think that could help reorient priorities. So I had dinner with a social worker years ago, and they were explaining how they respond to these quality measures. So the follow-up quality measures in particular. And she said, oh, well, what we do is we're discharging the patient, and then we just we schedule an outpatient appointment, and they kind of have that appointment, but as they're being discharged. So technically they've been discharged, and then they had this appointment. So then it shows that they had this follow-up, but to the patients, the patient doesn't view it as a follow-up because it's part of their discharge process. It's not like they came back 3 days later. And so that's how they're able to control their performance on their follow-up measure.
I think it is always helpful to have just an actual example of the different perceptions of what, follow-up care means to an individual who's actually leaving these facilities versus someone who works within it. Shifting gears a little bit, but all related, of course, since you've started doing this work and you've started really, exposing and shining light on these, huge gaps in the data that's available, as well as, the harms and injustices done within these facilities, what kind of responses have you gotten from institutions, inpatient, at like the state or federal level?
I will say I've benefited greatly from mentorship that has helped me edit my papers to be a little bit more mindful of multiple audiences. And I have found that frontline staff of psych facilities are totally, in general, enthusiastic even about my research, so long as I make it very clear that I'm not blaming them, and that I actually think that they also are victims of a very toxic system, right? We're talking about systems issues. It's not, no one individual is evil at all. And so I have found frontline staff to be, in general, not as defensive as psychiatry as a group. And I get mostly psychiatrists who review my papers, and they can be very defensive. They'll say, that's not my experience in the hospital I work in, which, okay, well, we're talking about research methods 101. And that's great that that's your experience in one hospital. But anyways, so I deal a lot with that. It's frustrating, and sometimes it's frustrating because I don't understand how they end up reviewing papers. So I experienced that pushback during peer review. But then the biggest, and I've actually experienced a lot of positive response, to be honest. But I'd say the biggest pushback I received was when I was a Ph.D. student, and I have to admit I was naive. I was very gung-ho, and I kind of did enter this research thinking, everyone wants to do good. And like, if I share data and share, if I point out how it could be better, everyone's going to be like, oh yeah, let's form a working group and let's try to fix things. And that's not how it ended up being. And I filed public records requests in the state of Massachusetts, a lot of them actually, for my dissertation. And that made some people feel a little bit uncomfortable, or they were curious about what my motives were. Was I like a journalist, or what was I going to do with these data? And so I faced some barriers there. And I was quoted $500,000 for data on restraint and seclusion. And I said, I don't have that money. But really they were just trying to shut me down. So I wrote a letter to the Secretary for Health and Human Services in Massachusetts. And I was very upset, and I documented 2 years of trying to get the information and all of the failures I saw. So they were not analyzing these data complaints. There was no internal like data management infrastructure, it seemed like, at least to me. And so I was giving all this feedback, and I was upset at how much it cost. Like, these data should be publicly reported, in my opinion. They should be on the internet. And this is ridiculous. And I'm a PhD student who can spend all my time doing this and gathering this information. What about patients and their families? They can't. I don't want to go to a place where they have 50 sexual abuse complaints a year. Or physical abuse, verbal abuse. So, and I want to know that, and I have the right to know that as a citizen, and everyone does. So shortly after that, I then got the data for free. Interesting. And then at some point, it reached the commissioner of mental health. I ended up having a meeting with the commissioner of mental health. My first meeting with her was lovely-ish. My second meeting with her, I was giving her feedback for my dissertation, and I wanted her. I had some outstanding questions about like co-occurring events at the time of. I was looking at the effect of an intervention, and I wanted to know if the state was doing anything that could have confounded this, and I wanted to know if my numbers looked correct in her opinion. And, I was just trying to do my due diligence, and I didn't want her to be blindsided. So I met with her, and I left that meeting crying, and I'm embarrassed. I should have been tougher, but she just was upset that I did my research. I don't know what else to say. And I don't want to imply anything, but I did leave that meeting. I went into the meeting really enthusiastic, and I did leave the meeting crying. And I will say the Department of Mental Health, they ended up implementing a revised critical incident monitoring system. And they did that after I published some work, but only after, and I shared it with them. And I was like, I'll give you free consulting. I was very enthusiastic. And it wasn't until a journalist covered it and asked them for a quote that then all of a sudden they implemented this new critical incident monitoring system, and they hired a full-time staff person whom I met. And I'm like, this is amazing, because yes, the data, it just was a mess. And so so now they have actual definitions of what physical abuse is. And in theory, they're doing a better job at collecting this information, which felt great to me. But I was frustrated because I really wanted to work in partnership with them. And I actually wasn't motivated to, like, I don't know, expose them or anything. I loved the idea of collaborating with them, but I found that they were less excited about collaborating, and it seemed to me that they were most responsive to journalistic coverage of issues. And like, that's the way to get anything done is to get stuff covered by a journalist, really. That's in one state, and she's not the commissioner anymore, and I won't say her name.
It sounds like the state taking your work and doing something tangible of kind of rethinking their system and hiring someone, but boxing you out of that process, it sounds like. So I'm curious too, just in thinking about your positionality, you're describing, wanting to do this more radical work or kind of push the bounds and think, think about these questions in bigger ways and in structure, from a structural lens, sort of what tensions emerge maybe with you holding those perspectives and trying to collaborate with others who perhaps, are coming at this from different angles.
There's always tension. And I think with this topic, inpatient psych, it's so intense. It's actually hard to have a conversation about it because it seems like people get triggered by certain words and then they automatically put you in a certain camp. So for me, because I care about how patients are treated, I sometimes people try to put me in the camp of you must be anti-psychiatry. And I struggle with that because it just kind of shuts down conversation. But it is true that I think that the field of psychiatry has caused a lot of harm. And that's a truth. And I'll say it and I'll tweet it. So I struggle with people being able to hold multiple truths and engage in like a nuanced conversation that is anchored in really caring about the people being impacted by this care, and mostly very marginalized, vulnerable populations in particular. Like kind of holding that at the center and collaborating and figuring out how can we best meet their needs, because I think we can find common ground around that end goal. But too easily, I think in this space, people are very quick to box you in and label you and dismiss you. But I think we all can agree that we don't have enough data. There's not enough research. And our current system is not patient-centered. And patients do need more power. There's individual differences always. So when I talk about evidence, I'm talking about in general. It's all kind of in general. And talking about at the systems level, what are the systems issues? Some people and some families do struggle to access the care that they need, and they do perceive their biggest barrier being the fact that they can't kind of force their loved one into treatment. And that can be valid, but also it can be a more nuanced issue beyond that being true for them. And I just wanted to clarify that.
You've been speaking to, which is fascinating, kind of these tensions that are emerging, how you can find strategies for finding common ground with people, at the systems level, payers, politicians even. And I also have seen in your work really like a call to action to include individuals with lived experience as partners in this process as well, either, as researchers or in the policymaking process. And also, you're in a unique position as well of being someone who's playing in that dual role of a researcher and carrying your own experiences. So I'm curious if you could speak more to what, meaningful inclusion looks like of a meaningful partnership and collaboration, because we've also seen, right, so many examples of running a risk for co-opting individuals' voices or taking advantage of their testimonies, or not, only paying lip service to a collaboration that's, maybe not that meaningful. So I'd love your thoughts on that.
So obviously there's like many things that need to happen. The first one is, and this is definitely not sufficient, but schools that are training academics who are going to end up researching the mental health care system in some capacity, either at the clinical level or the systems level policy, especially need to value lived experience as a dimension of diversity and inclusion, and take that very seriously. Because as we were talking earlier, unfortunately, it has been viewed and felt as a liability as opposed to an asset. And it really is an asset, because the truth is that we all have bias. As researchers, there's no such thing as objective research. So we're all coming to the table with bias. And it's really a question of how can we make that bias more equitable? And so I would argue that the way we should be viewing bias is trying to put more weight and more value on the types of biases that are more marginalized or underrepresented. Because there's an inherent power imbalance, right? And so one way to address that is to put more weight on those who have less power. So that's what we need to do in the academy. And obviously it takes changing people's attitudes, but pressure and like true pressure on diversity and inclusion as the like hub of this, because disability and lived experience in generally just are really not prioritized, I have found, in diversity and inclusion efforts, and they should be. So that would be one, and that would be a way for us to get PIs with lived experience in leadership roles, eventually real big leadership roles after time. And I've actually met some people who have lived experience who have leadership roles. So they exist, but I don't think there's many of them, at least not like lived experience of involuntary hospitalization per se. And if they exist, it's hard to know. And so it's hard to find allies or find like your group because everyone's trying to hide it. It's just not good. So yeah, it's hard to find your peers and get the support and et cetera. So that would be one. And then obviously it's a structural issue. So we need funders like the NIH to really value this, community partnerships in a meaningful way where they put money on the table. But at the end of the day, these grants are reviewed by our peers, and, other academic researchers. And so it takes, at the end of the day, it really takes people buying into this as something that's important and being convinced. Because even if the NIH says, oh, we have to have these partnerships, if the reviewers don't think that that's important, they're not going to be critical of someone's grant. You're not going to be critical of how meaningful the partnership is between the researcher and the community partners. And it is important that we partner with community members, both individuals and organizations, because first of all, we are only one person, as if we're someone with lived experience as a PI. So we don't have the diversity of experiences that we should be tapping into. And we have our own privileges, that biased our own experiences. And also, just by having a PhD makes someone incredibly privileged and sitting in a different spot, no matter how your experiences were prior to getting a PhD. So we're different and very privileged. And so it is important to maintain those relationships. So, but academic research is such that we do depend on grant money, and the grants run out, and it's hard to maintain continuous relationships with community providers or community partners because the grants run out. We can't pay them always for their expertise or for partnering with us. And then if we don't pay them, then that's not good. We're exploiting them. I'm lucky in that I'm hard money, so I'm kind of excited about that. But a lot of people are trying to do this work in soft money environments, which means that they have to raise their entire salary through grants. And so, yes, you might get money to do an amazing project where you're collaborating with community partners and people with lived experience, but you have to then apply for the next grant and the next grant, and you have to be opportunistic and just kind of like do whatever the granting agency wants you to do to get the money to survive. So that should be addressed. There's a lot that should be addressed to change the incentives of researchers so that we could support them in being able to do this work. And I do know there are a lot of researchers who would love to be able to do this work, but they're also trying to survive themselves. So yeah, with the people who have the purse need to value this, and they need to be strategic about how they use their purse. And then us as researchers, as a collective, we have to talk about this and trying to change the minds of our colleagues so that when they're at the table, they're on our side, and they can be convinced and maybe even speak up on these issues, because that's what it's going to take.
A theme running through our whole conversation, right, is the power. It seems to be coming back again and again to the power and the status quo, right, of how it that maintains the power is being concentrated in these, it's other academics who are reviewing your papers, who are reviewing your grants and holding, our existing models in place. Are there any kind of examples you could give of ways that you've collaborated with partners or individuals with lived experience in your own work?
Yes. So there's doing the research where I'm actually interviewing and collecting information from people with lived experience and asking them, what exactly do you think needs to change? And then letting those data then inform what I then prioritize studying moving forward. The problem that I have faced as someone who's early in my career is I haven't had money to be able to pay an advisory board, which has been my dream. And I have startup funds now through my faculty position. So what I'm doing now is I would love to have I would love to have two different types of advisory boards that I collaborate with on a continuous basis, in ways that we just have a relationship, and I don't necessarily go to them with a project idea always, but that we kind of co-develop project ideas. But I'd like to have two where one is more national, general, people with lived experience, and maybe some representatives from advocacy organizations. And then one that's St. Louis based, because I would love to do research that has a positive impact on the folks in St. Louis. But I just moved here a few months ago, and there is a history here, and I'm trying to listen and kind of just get a sense for the landscape and not dive right in, but just kind of understand who has existing relationships, setting up meetings with folks who do this type of work at the school. And then eventually I'm going to start having meetings with people in the community, healthcare providers that provide community care, but other stakeholders and advocacy organizations that are very much St. Louis based. But it's kind of, it's not going to happen overnight. Yeah, to be able to do it appropriately, and it's a relationship, and I want it to be a long-term relationship. So, and I try to hire RAs with lived experience, and I partner with students at different universities who have lived experience, and I try to do my best to support the workforce by. If someone reaches out to me and wants to collaborate on a project, I try to be generous. But I'm also trying to figure out how to juggle lots of things currently and manage everything and not be a terrible mentor, right? So, actually be able to respond to people's emails and get drafts back to them. But those are the things I'm doing now with my limited resources.
On that note, I'm curious if there's any ways, thinking about the people who will be listening to this podcast, if there's any way that, at any level or even down the line could connect with you or get involved or share their story in a way that, might be, if they feel moved to do so.
Absolutely. I would love that. I love my work, and I get really energized when I am connected with people with lived experience. I love it. And sometimes it is hard to hear some of the stories, I will admit, because it can be really upsetting that people have experienced what they've experienced. And I hear similar stories over and over again. That's really upsetting. But I'm very open. People can reach out to me. I do have a lab that I've started, and I have hired a couple of people. And so I do think my capacity will be increasing in the near future. But also just, I would ask people to have some grace if I take a while to get back to you, because that might happen. I'm starting to teach on Tuesday, so I might be distracted for a little bit, but definitely very open to people reaching out, collaborating, or just getting in touch, and then we can maybe later down the road we work on something together. But yeah.
Amazing. I'm excited to hear that. And then I think And you've spoken to this a little bit in terms of how, the more you learn, the angrier you get, the more stories you hear, that fuels your energy to do this work and be in this work. But I'm curious, kind of how you continue to maintain hope, if there's more you could say around that, and also what do you hope for in the future of these systems, or what do you see as your long-term vision for how things might look differently?
Being pragmatic, my long-term vision, I would absolutely love it if in my lifetime I could at least see people caring about these issues and trying to address them, even if not getting it right perfectly, but there being a consensus in the mainstream that these are issues, and that the issue isn't that, oh no, there's gun violence, we have to lock people up, or oh no, the issue, a recognition that there's an issue of people being dehumanized in our systems, and how can we fix that? How can and just a reckoning of the violence that's been inflicted on people in a similar way. And I don't want to co-opt this, and I want to be very clear about that, but in a similar and intersecting way, actually, with police violence. If there was just a mainstream reckoning that this is an issue, first of all, and then there's the debate of how do you fix it. But I am afraid right now there's not an awareness of the issue, the true issues, and that we're still debating reality. Is reality? Should we listen? Should we even treat psychiatric patients as people? It feels like that's kind of the debate that I've been hearing, and that's unfortunate. And I would love for us to get to the point where we agree these are humans, we are humans, and the way we've been operating with our mental health care treatment system has been absolutely unacceptable. And we have to figure out how to do a better job, and have humility in that process, because it will take a lot of people having humility, because a lot of people have been participating in it. But that's the nature of life in these systems. We all are implicated. That's my future hope.
Thank you so much, Dr. Shields, for being so generous with your time. And I wanted to give a little space if there's anything more you'd like to say.
And we touched on this briefly, but I do want to just reiterate that the current mainstream argument that we need more psych beds, that's like the loudest argument right now. Well, I have a lot of issues with it, and I won't describe all of them, but it's important that people really be clear-eyed and not forget that we do operate in a market-based system. So if you want a provider organization to be incentivized to add more beds or open up new psychiatric facilities, ask yourself what you think some of the unintended consequences might be. We treat, for some reason, psychiatric care as it's like just a bunch of benevolent people, and we don't view other types of consumer goods in that way. We seem to be able to be critical as a society of healthcare in general, and then also other consumer goods like shoes and clothing and, exploitation of the labor force and all that. But for some reason, with mental health care, it seems like if you even bring up this critique, it's almost as though people get offended, or it's too much to process. I don't know what it is, but it is reality. And I would just ask people to have some appreciation for it being a complex issue, and potentially that there are issues of profiteering and exploitation of patients.
I'm really glad you kind of went into a bit more depth with that, because I think too it's one of the most what we hear so much need to increase access to care, increase access to beds, to inpatient care, and without any of sort of what this picture that you've painted for us together today of all of the nuances and complexities to that. And before we can just increase access, let's think about what is this care that's really being provided. Thank you so much. I feel inspired, and I just really appreciate your work and the work you're doing and the time you've shared with me today.
Great. And thank you so much for inviting me to do this. It's energizing, and it was nice to meet you, Julia.
Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.